And so now we move to Guy Brassel from Ghent. And Guy's talk is about the mechanisms of resistant to treatment in COPD and severe asthma.
Thank you, Walter, and I want to thank Leo, Fabri, and Enrico for inviting me. It's always a pleasure to come to Italy and Modena. And so, of course, you gave me a huge topic. It's mechanism of resistance to treatment in severe asthma and COPD. But I think it's a crucial topic because if we understand the mechanism of resistance to the current treatments, we pave the path towards new treatments. These are my disclosures. And I will mainly focus on severe asthma and then in a short period on smoking asthmatics and COPD. But I totally agree with Ian Purford that we need to move towards phenotypes and endotype-based treatments. So both asthma and COPD are heterogeneous. They consist of several phenotypes. But we need to dissect the underlying cellular and molecular mechanisms, which are the endotypes. And then we can treat the patients, the different clinical phenotypes, according to the underlying endotype. And here you see the asthma phenotypes, as Sally Wenzel has pointed out. One important issue is the age at onset. So you have the childhood onset versus the adulthood onset asthma. That's already very important and very easy to ask your patient. And then there's the underlying inflammation, which can be T helper 2. I prefer type 2 driven, meaning eosinophilic inflammation, or non-type 2, non-eosinophilic inflammation. And here on the y-axis you see the severity, which is increasing. And you see that childhood onset asthma, which is mainly allergic, you have the whole spectrum from mild, moderate to severe. Whereas the late onset, adult onset asthma, which starts at the age of 35, 40, and often is associated with nasal polyps and eosinophilia, these patients often have severe asthma in 1 or 2 years' time. And then you have, of course, the neutrophilic asthma and other forms of non-eosinophilic asthma. So what I use in my clinical practice, where I see many adult patients with severe asthma, is I try to determine whether they are allergic or not, whether the asthma started early on or late on, and then I try to determine the airway inflammation, whether it's eosinophilic or neutrophilic, and I use always pheno and blood eosinophilia. Because blood eosinophilia is significantly associated with sputum eosinophilia. We cannot use blood neutrophilia because this is not associated or correlated with sputum neutrophilia. So that's important to keep in mind. And I totally agree again with Ian Purford that inhaled corticosteroids, they are very efficacious in diminishing eosinophilic airway inflammation, irrespective of the label, whether it's asthma or COPD or whatsoever you call it. When there's eosinophilic airway inflammation, your patient will benefit from treatment with inhaled corticosteroids because the T helper 2 lymphocytes, which reduce interleukin-5 and attract eosinophils, will disappear. And the production of interleukin-5 by T helper 2 cells will decrease and the eosinophils will diminish. Of course, long-acting beta-2 agonists, they have other mechanisms of action. And if you combine ICS with LABA, especially in asthma, this is a very efficacious treatment. Now we need to take into account that we have different CD4 positive T helper cells. We have the regular T cells, which prevent us from autoimmunity and allergy. Then we have these T helper 2 lymphocytes, which produce interleukin-4, IgE switching, interleukin-5, eosinophilia, interleukin-13, mucus hypersecretion. So this is eosinophilic inflammation. And then we have T helper 1 cells producing interferon gamma, and these cells may protect us from intracellular bacteria, such as mycobacteria, tuberculosis. So that's immunity against intracellular bacteria. And then we have the T helper 17 cells, and these cells produce interleukin-17, and this is leading to neutrophilic inflammation, and this protects us against extracellular bacteria, such as pneumococci. So this is important to take into account. But now what we have learned in the recent years is that in addition to these classical CD4 positive T helper cells, which react in an antigen-specific manner, we have also these innate lymphoid cells, ILC, innate lymphoid cells. So they also can produce these different cytokines, but they do this in an antigen-independent manner. And I will focus mainly on these three subsites. So the innate lymphoid cells type 1, they produce also interferon gamma and protect us against viruses and intracellular bacteria. And then for this talk, the most important is the innate lymphoid cell type 2, which produce IL-5 and thereby eosinophilia, and also IL-13 and thereby smooth muscle contraction and goblet cell hyperplasia, leading to immunity to helminths. That's their natural function. And then you have the innate lymphoid cells type 3, which produce IL-17, so that's the counterpart of the T helper 17 cells, and they induce epithelial cells to produce IL-8 and thereby neutrophilic inflammation and then antimucosal peptides. And they are protecting us against extracellular bacteria. So we recently characterized these innate lymphoid cell subsets in human lung because all the work has been done so far in rodent models. And so I will come on later on the results of this paper. So now starting with severe asthma. It's important to make a distinction between severe eosinophilic asthma and severe neutrophilic asthma. And of course, there's the excellent work by Van Chu and colleagues on the guideline on severe asthma. But the definition of severe asthma is resistance to treatment. So patients with severe asthma, they require a treatment with high-dose inhaled corticosteroids and a second control, mostly a LABA, and sometimes they need systemic corticosteroids. This is different from uncontrolled asthma, because uncontrolled asthma, which is very frequent, is mostly due to poor compliance to inhaled treatment and poor inhaled technique. And it can be also persistent allergen exposure and, of course, smoking. Active smoking, passive smoking, they are associated with uncontrolled asthma. Of course, an incorrect diagnosis and significant comorbidities will also lead to uncontrolled asthma. So severe asthma is heterogeneous, and on the left you have the allergen-driven T helper 2 cell mediated IL-5, eosinophilia, and eosinophilic asthma. But there's also neutrophilic asthma, which is not due to allergens, but by viruses and bacteria, leading to the activation of epithelial cells and macrophages, and then the production of interleukin-8, which is a chemokine which attracts neutrophils. And these neutrophils, they produce neutrophil elastase, which induces emphysema in CPD, but which is also a potent stimulus of mucus, of goblet cell hyperplasia, and thereby contributes to neutrophilic asthma. But it's important to take into account that also eosinophilic asthma is heterogeneous. So on the left, you have the allergen-induced T helper 2 cell mediated eosinophilic inflammation, where the T helper 2 cells, they produce not only IL-5, and so eosinophilia, but also interleukin-4. And this will induce switching of B cells towards IgE antibodies. And so there you have this IgE dependent T helper 2 mediated eosinophilic inflammation. On the other hand, you have, independent of allergens, you have epithelial cytokines which are produced upon exposure to bacterial, virus, or pollutants. And these cytokines are interleukin-33, interleukin-25, and TSLP, the thymic stromal lymphopoietin. And these cytokines will activate these innate lymphocyte type 2. And these cells, they produce high amounts of interleukin-5, and thereby leading to eosinophilia, but there's no IL-4 production, so there's no IgE switching. And thereby you have eosinophilic inflammation, but in the absence of allergy. So that's very important to dissociate eosinophilia and allergy. And so our hypothesis is that this pathway, which is driven by allergens and T helper 2 cells, is mainly sensitive to inhaled corticosteroids in the majority of patients. And so that's the old-term extrinsic asthma, or the early onset allergic eosinophilic air inflammation, sensitive to inhaled corticosteroids. But this pathway, which is often seen in the patients with late onset asthma, in the absence of allergy, but with major eosinophilic inflammation and driven by innate lymphoid cells type 2, is resistant to inhaled corticosteroids. And these patients often need oral corticosteroids, bursts of oral corticosteroids, and sometimes maintenance treatment with oral corticosteroids. What's the evidence for this? So a recent paper by Stephen Smith from Paul Burns' group has shown that these innate lymphoid cells type 2 are increased both in blood and induced sputum of patients with severe corticodependent asthma and the persistent airway eosinophilia. So here you see, compared to the mild asthmatics, these innate lymphoid cells type 2, which produce IL-5, are significantly increased in the blood of patients with severe asthma, and also increased in the sputum of patients with severe asthma, who are treated with high-dose inhaled corticosteroids and even oral corticosteroids. So meaning that these innate lymphoid cells type 2 are resistant to the corticosteroids. And you see the classical T helper cells, T helper 2 cells, which are CD4 positive, and there's no difference between mild and severe asthmatics in the sputum, and even a lower amount of IL-5 producing CD4 T cells in the severe asthmatics. Whereas the innate lymphoid cells were the predominant source of interleukin-5 in these blood and sputum of patients with severe asthma. So here you see in sputum, the innate lymphoid cells type 2, up to 100% of these cells produced interleukin-5, and also in the blood. So these innate lymphoid cells type 2 are really the drivers of the eosinophilic inflammation. Now we have treatments, new treatments for eosinophilic asthma, and that's anti-IL-5. We participated in the MENSA trial with mepolizumab in severe eosinophilic asthma, and this will be addressed in Van Jung's presentation. But you see a clear reduction in the exacerbation rate compared to placebo, both with the intravenous form of mepolizumab and the subcutaneous form of mepolizumab. But I will mainly focus on this study, because here with reslizumab, another monoclonal antibody, there was also a significant reduction in exacerbations in patients with uncontrolled severe eosinophilic asthma compared to placebo, less exacerbations in the patient treated with reslizumab. But interestingly, the more severe the patients, the better the response. So if they were only on inhaled corticosteroids, you had a 50% reduction in exacerbation rate. If they were on ICS-LABA, the majority, you have a 55% reduction in exacerbation. But if they were on oral corticosteroid, you had even a 70% reduction in exacerbation. And therefore, we proposed to perform a subgroup analysis, not to rescue a negative study, because the study was very positive, but to investigate the underlying pathogenesis. And here on the left, you see the overall results. So placebo in yellow, and in green, the reslizumab-treated patient. Overall, you have a 54% reduction in exacerbation, which is great. And then, based on early onset versus late onset asthma. So one question, when did your asthma start? You see that the late onset asthmatics in placebo arm, they have a higher frequency of exacerbations compared to the early onset. So the unmet medical need is higher. But look at the effect in the early onset asthmatic with reslizumab, a 42% reduction in exacerbation, which is very significant. But look here, in the late onset asthmatics, a 75% reduction in exacerbation. So a huge effect. Lung function. Overall, there's an increase with 110 ml in the treated patient with reslizumab. In the early onset, and this is of course below 40 years of onset, you see a huge placebo effect. In the placebo arm, there's an increase of more than 140 ml. Whereas in the late onset asthmatics, driven by these innate lymphoid cells type 2, you have almost no placebo effect, and a huge effect of anti-IL-5 reslizumab. So again, pointing towards different mechanisms in eosinophilic asthma depending on the age at onset. So to my opinion, mild to moderate allergic asthma is ICS sensitive, but severe eosinophilic asthma, when it starts at late onset, at the age of 35, 40, it's ICS resistant. Okay. So the best target for anti-IL-5 in eosinophilic severe asthma is in the late onset asthma. It's here, the non-allergic severe late onset asthma. Okay. Now switching from eosinophilic asthma towards neutrophilic asthma. And there we have the macrolides. I have to admit I'm obsessed by macrolides because the major disadvantage is that they are cheap, but they have both anti-inflammatory activities and antimicrobial activities. And so they can interfere with the growth sensing by Pseudomonas aeruginosa, but also by Haemophilus influenzae. And so they can also stimulate phagocytosis of bacteria by macrophages and also the erythrocytosis, the phagocytosis of dead cells by macrophages. And they inhibit IL-8 production and thereby neutrophilic inflammation in airway diseases. And again, macrolides, they are efficacious in chronic neutrophilic airway diseases independent of the label. Whether it's cystic fibrosis, of non-CF bronchiectasis, or diffuse bronchiolitis in Japan. Formerly, this was a lethal disease. With the treatment with erythromycin, it could be cured. And then in severe neutrophilic asthma, we provided evidence that macrolides are effective. By this randomized controlled trial, investigator initiated because there was no company interested in performing this trial because it's a very cheap drug. And so we performed the ASISAS trial, so a multi-center randomized double-blind placebo-controlled trial, and I totally agree with the endocrinologist of yesterday that it is blood, sweat and tears to perform. But the results were positive because in those patients with severe neutrophilic asthma, so in the absence of eosinophilia, you have compared to placebo less exacerbations and thereby so a significant reduction in exacerbations. So the add-on therapy in severe asthma should be based on the underlying endotype. And so anti-IgE we use already more than 10 years in severe allergic asthma. Anti-IL-5 is the best add-on therapy in late onset eosinophilic asthma, and macrolides in the neutrophilic asthma, but not in smokers. So in current smokers, it's not effective. Okay. Then I will give you some minor points on microRNAs. Because microRNAs are very interesting new future treatments. So messenger RNA is, of course, the RNA which is transcribed from coding regions for proteins. But microRNAs, they are not coding for proteins or peptides, but they are regulating the expression of other messenger RNAs. And they can induce degradation of messenger RNAs, or they can block translation process. And they are very pleiotropic. So one microRNA can regulate several gene products. And thereby, they can be pleiotropic as ICS are. So we performed, and this paper is just accepted. So yesterday was accepted in JACC, so brand new. We compared in induced sputum of neutrophilic asthmatics, eosinophilic asthmatics, and healthy subjects, the profiling of the microRNAs. And there are thousands of different microRNAs. And you see they cluster according to the underlying endotype. And then this is the volcano plot. And here you see there are 3 microRNAs which are significantly upregulated in patients with neutrophilic asthma. This is the screening cohort. We validated this in an independent cohort of asthmatics, and depending on the severity, mild or severe asthma, or eosinophilic or neutrophilic. And as you see, for example, microRNA 639 is significantly upregulated in severe asthma, but especially in the neutrophilic asthma. And this is thanks to an excellent collaboration with Fabio Riccardiola from Torino. This is on bronchial biopsies from patients with severe neutrophilic asthma, and here you see the in situ hybridization of this microRNA 629. And you see significant expression in the epithelial cells of that microRNA. And linked to this, you see an increase of neutrophils in the airway epithelium, a positive staining for neutrophil elastase. And when we then in vitro administer a mimic of this microRNA on human bronchial epithelial cells, we induce the expression of interleukin-8, which attracts neutrophils. So meaning that an antagonist for this microRNA, an antagomere, would be an interesting treatment strategy for neutrophilic asthma. And so antagomeres have already entered clinical trials. For example, an antagomere for microRNA 221 for the treatment of chronic hepatitis C has been published in the New England Journal of Medicine 2 years ago. So that was on severe asthma, where we have new tools, new treatments, depending on the underlying endotype. Smoking asthmatics, only 2 slides. We know that smoking and asthma alters the airway inflammation. It adds a neutrophilic airway inflammation on top of an underlying eosinophilic inflammation. And it induces corticosteroid insensitivity. So that's an important message. Of course, you have increased symptoms in smoking asthmatics, an accelerated decline in lung function, a reduced response to inhaled corticosteroids, and you have an altered airway inflammation, a mixed neutrophilic eosinophilic inflammation. So smoking cessation is key in patients with asthma. And then coming to COPD, chronic obstructive pulmonary disease, we know there that the adaptive immune response is mainly consisting of T helper 1 cells and T helper 17 cells. But as I mentioned, innate lymphoid cells have been discovered only recently. So we investigated their distribution, comparing healthy controls with patients with COPD on lung resection specimens. And you see no difference in the numbers of innate lymphoid cells type 1 and 2, but an increased number of innate lymphoid cells type 3 in COPD patients compared to the controls, so without airflow limitation. And so these innate lymphoid cells type 3, they are producing interleukin-17. And here you see the distribution in controls without airflow limitation and patients with COPD. So the innate lymphoid cell type 3 cells is significantly increased in patients with COPD. And as you know, these innate lymphoid cells type 3, they produce interleukin-17, and thereby they induce neutrophilic inflammation, which can be protective against the pathogens within the airway lumen, as Haemophilus influenzae, but can also, of course, be damaging. I will skip this, the reversing corticosteroid resistance in COPD, because this is mainly based on in vitro experiments. We need clinical in vivo trials to prove this, but I'm happy to see macrolides among one of the possible drug classes to reverse corticosteroids insensitivity in COPD. This Ian has already shown, but I think it's important to take into account that the highest benefit you have here with an increased blood infillia, but this already within the normal range. So the values of more than 400 eosinophils per microliter, this is an obsolete upper limit of normal. In our lab at the Ghent University Hospital, it's 270, the upper limit of normal of blood eosinophils. Okay. And I have a very simple scheme, totally different from GOLD, that if you have a patient with COPD, you look whether he or she has exacerbations, yes or no. If there are no exacerbations, then if it's moderate airflow limitation and moderate symptoms, 1 long-acting bronchodilator is sufficient. If you have severe symptoms and or severe airflow limitation, you combine 2 long-acting bronchodilators. But if the patient has repetitive exacerbations, please have a look at the type of the exacerbations. If the patient needs repetitive courses of antibiotics and the blood eosinophil count is low, then we should avoid inhaled corticosteroids in this patient population. And the gorilla is not better than the lion in these patients. It's only in those patients who have COPD and repetitive exacerbations with a high blood eosinophil count and they need oral corticosteroid courses to treat the exacerbation, then the triple therapy is indicated. And then the gorilla is the best choice. Okay. So as a conclusion, severe asthma is very heterogeneous. It encompasses non-eosinophilic, neutrophilic, and eosinophilic asthma. The eosinophilic air inflammation in asthma can be induced by T helper 2 cells, and that's mainly the case in the early onset, childhood onset allergic asthma, and this is sensitive to inhaled corticosteroids. Whereas in the non-allergic late onset asthmatics with eosinophilia, this is driven by innate lymphocyte cells type 2, and these have receptors where there are novel compounds, novel drugs in developing, even oral treatments. Macrolides, they decrease the rate of exacerbation in neutrophilic severe asthma, but they are very cheap and they were not recommended in guidelines. And then you have the targeted therapies in severe asthma. So the targeted therapies in severe asthma, the 3 underlying endotypes. In this allergic eosinophilic asthma, we can add anti-IgE on top of ICS/LABA, high dose. But in this group of the non-allergic eosinophilic asthma, we add anti-L5, mepolizumab or reslizumab. And then in the neutrophilic ones, we can add macrolides provided that the patient is a non-smoker or an ex-smoker. Current smoking prevents efficacy of macrolides. And then, of course, I thank my collaborators at Ghent University, especially Tanja Maas, who performed the microRNA study on severe asthma, just published in the JACI, and then Katrien de Grove and Sharon Provost, who performed the characterization of innate lymphoid cells in human lungs, just published in PLOS ONE. I thank you for your attention.
Thank you very much, Guy. We have one comment from Sergio Bonini. There are 3 questions. Please, very short questions and very short answer.
I was very interested by the hypothesis that in eosinophilic asthma, resistant to steroids may depend on the type of cells involved, Th2 or ILC2. This would have an implication that since Th2 cells have a strong polyclonal IgE activation, and allergy is just a result or a counterpart of this, it would mean that total IgE could be a marker to predict steroid resistance in eosinophilic asthma. This is quite an interesting hypothesis, but the data we have about the relevance of total IgE as a predictor of response to treatment are very limited.
I totally agree, and so anti-IgE omalizumab is a good drug, but total serum IgE is a very bad biomarker. So what counts is the local antigen-specific IgE. That's what's driving the inflammation. The local airway concentration of antigen-specific IgE. But we do not measure this. And we base our dosing of omalizumab on total serum IgE, which is a very bad biomarker. Whereas for anti-L5, mepolizumab and reslizumab, we have the perfect biomarker, blood eosinophilia, because it's giving us the correct phenotype, it's a predictor of response, and it's a therapeutic target. So it's the ideal situation.
A wonderful presentation. And I have 2 questions to the phenotype versus endotype. For example, in non-allergic eosinophilic asthma late onset, we have very often nasal polyps. And these nasal polyps are very, very important for the course of the disease. This is phenotype or not endotype. This is one point. And I've done
I will immediately answer.
Or combination.
Yeah, I will immediately answer. The innate lymphoid cells type 2 have been for the first time described in humans in nasal polyps. And so, meaning that in these patients with late onset asthma and nasal polyps, this pathway of innate lymphoid cells type 2 is the main driver.
Wonderful. But we have to learn that we have to look at upper and lower airways in order to understand these type of late onset asthma. And the second thing is neutrophilic asthma. I have doubt that we have so many patients with neutrophilic asthma. Here we're also missing a link to a special phenotype, and this is bronchiectasis. And from our new CT scans, we know that even subtle neutrophilic bronchiectasis may drive neutrophilic sputums. And this has to be taken into account to understand these diseases.
You're absolutely right. So I loosely use the term neutrophilic asthma. I know that other colleagues they use it in a much more restricted part. I would need to call it non-eosinophilic asthma, because what we need is a positive marker of neutrophilic airway inflammation by, for example, VOX, volatile organic compounds. We have FeNO, nitric oxide, for eosinophilic inflammation. There should be VOX, volatile organic compounds, which we can measure in the exhale breath immediately, so real time, and they give us an indication that the inflammation is neutrophilic, with therapeutic implications.
Wonderful presentation, just like it very much. I would like to ask you a kind of a basic question related to the lymphocytes, to the innate lymphocytes. I mean, how do they relate to the regular, you know, the Th1, Th2 lymphocytes? I mean, what is the relation? Are there one or another? Do they contribute to the adaptive immunity?
Yeah, so now I separate them as two different sets of lymphocytes, but of course they collaborate. And so it's a spectrum. And they go also via the thymus, but they have other differentiation factors, and they leave earlier the thymus. And now with RNA profiling at the single level, cell level, they can track these innate lymphoid cells versus T helper cells, even in vivo in rodent models, by labeling with, for example, with GFP, green fluorescent probes. So I think this is very important to know the ontology and the different transcription factors involved in the development.
So, Guy, that was a lovely talk, but towards the end you came up with a nice simple scheme for management of COPD, which actually is identical to the scheme that I put up for airways, this one, except I did a gold-style table, but there's no difference. So one question is, why just COPD? Is this not airway specific?
No. So,
could we not simplify things?
No. At that point, I still prefer to use the terms asthma and COPD, but in both instances, we need to further characterize them. And we say, for example, this patient has asthma, and it's eosinophilic allergic, or it's non-eosinophilic. And then in COPD, it can be with or without blood eosinophilia. We need to characterize them further. But this is, it should be noted, personal opinion. But it makes much more sense to treat the patients according to the underlying inflammation than an ABCD algorithm, which is totally independent of the underlying pathology. I give the floor to Oliver. Thank you.
Yes, I confirm that we move now. Thank you very much.